It is a great honor and a pleasure to me to have Professor Gamal Fahim. He is a very well-known figure in the cardiology in Mansoura. He is a professor of cardiovascular, consultant cardiac catheterization, member of the Egyptian group of the treatment of heart catheter. He is a professor of cardiology in cardiology department of Mansoura University. This is his birth date in 64 in Mansoura. And during his career, he had a chance to go to UK, to Northern General Hospital in Sheffield, staying as senior registrar between 1995 to 1997. So 2 years of experience in the United Kingdom. He's a member, active member in many societies in Egypt, Arab, and the American Society of Cardiology. He's a registered reviewer for the American Journal of Cardiology. We enjoyed, these are the two presentations that we enjoyed to attend and to listen to Professor Gamal Fahim about contrast and about acute heart failure. Always we are happy to meet Professor Gamal, and this is an old photo. I think Professor Gamal, you remember this photo with our great Professor Helmi Bakr and our colleagues. Today we have Professor Nabil Farag. He is the Professor of Cardiology and Chief of Cardiology Department at Ain Shams University. He is, this is one of his presentations 9 years ago at Urology and Referral Center, our coronary intervention in dialysis patients. He's the President of Egyptian C2O Club, Vice President of Egyptian Association of Atherosclerosis and Vascular Biology. He's the Past President of the BVD Working Group, Past President of Cardiology Department in Dar El Fuad. He's the Fellow European Society of Cardiology, Fellow of the Society of Cardiovascular Angiography and Intervention. I like his publication in collaboration with the European Society of Cardiology. This is one of his publications because he is a member of the heart failure long-term registry, European Society of Cardiology, EORP. And this is another, this is the association between loop diuretics dose change and the outcome of coronary heart failure. Chronic heart failure, and this is the molecule of sacubitril valsartan, eligibility and outcome. I think all these are interesting, and this is a very interesting article from Egyptian gender differences in Egyptian patients hospitalized with heart failure. Today we are expecting a hot presentation, very interesting presentation, hot discussion with the presence of two eminent professors and speakers, Professor Gamal Fahim and Professor Nabil Farag. I'd like to stop here, allowing Professor Gamal to take the lead and to have his presentation. So Professor Gamal will speak about coronary intervention in patients with chronic kidney disease as well as transplant patients, and we will be ready for Professor Gamal. Professor Gamal. Go ahead, please.
خليك يا حسين. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام. السلام عليكم جميعا. It is a great pleasure for me to be with you in the next few minutes. And it is great honor also for me to be invited by my colleague and my best friend, Dr. Hussein Sheashaa. He's a good friend many years ago, and he is a very active scientific, and it is a great pleasure for me to share with you in this next few minutes. And I'm sorry for the delay. I have a busy today in coronary intervention and cardiac, so I am very sorry. Our topic today is about coronary intervention in patients with CKD and post-transplant. We will talk about the relationship between the heart and kidney, then CKD and cardiovascular risk, diagnosis of acute coronary syndrome in patients with CKD, prognosis of coronary heart disease in patients with CKD, treatment modalities, role of percutaneous coronary intervention CKD. I prepared a few minutes ago a case with BSI in a case with end-stage renal disease and hemodialysis, and then the conclusion. The heart and kidney, there is a strong relationship between the heart and kidney in terms of hemodynamics and regulatory function. Most kidneys receive about 20 up to 25 of cardiac output, so 1/4 of cardiac output. This flow is several times greater per unit of weight than in most other body organs. Oh, I'm sorry. As we see in the diagram, the microanatomy of the kidney, each kidney have about 1 million glomeruli, and this is the circulation and the filtration membrane. On the other hand, the kidney have a central role in electrolyte balance, protein production and catabolism, and blood pressure control. The communication between the kidney and the heart occurs at multiple levels. At the level of sympathetic nervous system, level of RAS system, and many neurohormones, vasopressin, endothelin, and natriuretic peptide. CKD, as you know better than me, we have different stages from grade 1 up to grade 5 according to glomerular filtration rate. You know better also than me, in our daily practice, we depend on serum creatinine, which is not an accurate in assessment of renal damage. Glomerular filtration rate is more sensitive and more accurate. And this is the grades of renal dysfunction according to glomerular filtration rate. Mortality of patients with CKD and end-stage renal disease, cardiovascular causes are the most common. Arrhythmia and cardiac arrest and acute myocardial infarction contribute to the majority of cases due to coronary heart disease, acute coronary syndromes, and its complication, arrhythmogenic death, pump failure, and cardiac arrest. Heart failure contribute to about 15% of mortalities, stroke to 7% of cases. It is well known that with advancement in CKD or increase in the grade, there is increased cardiovascular mortality. In patients with ST elevation myocardial infarction, about 30% of patients have a degree of CKD with different grades. In patients with non-ST elevation myocardial infarction, CKD with different grades is present in about 43% of patients. Diagnosis of coronary heart disease in patients with CKD is like patient without CKD. But it's important to note that a typical presentation of patient with CKD for coronary heart disease may present with angina equivalent, shortness of breath, dyspnea, and effort, and it may present with classic symptoms of typical chest pain. Presence of CKD in patient with coronary heart disease and acute coronary syndrome, it has a very worse prognosis. And this is related to degree of renal impairment. We found that in patient without CKD, the in-hospital mortality 2.3. It increases to about 32% in patient with end-stage renal disease. The same for patient with non-STEMI. As the renal function progressively deteriorates, the mortality increases. We have multiple factors to explain this very bad prognosis of coronary heart disease among patients with CKD. First, excess comorbidities like diabetes and left ventricular dysfunction. Toxicity of drugs used in treatment of coronary artery disease, mainly antithrombotics. Antithrombotics, which include litixrap, TBA, streptokinase, dual antiplatelet, parenteral antiplatelet, and anticoagulant, and many other biologic or pathophysiologic mechanisms unique for renal patient. This includes first, excess thrombin generation and increased thrombogenicity, increased thrombus formation. And all of you know that the pathogenesis of acute coronary syndrome is a thrombotic event, plaque rupture and thrombus formation. On the other hand, we have a paradox. Patients with CKD have a higher bleeding tendency due to impaired platelet function. So we have both increased thrombogenicity and at the same time increased bleeding risk. We have in patient CKD a more severe coronary heart disease, more proximal lesion, let's say, which affect the left main trunk, proximal LED, proximal circ, proximal right coronary. More proximal, it means we have a large area of myocardium at risk for necrosis and ischemia. In CKD patients who have an extensive coronary heart disease, extensive with higher syntax too. Extensive means cerebral, left main, long lesions, calcified lesions. All of this for us in cardiology, for interventions, this we call adverse lesion criteria. It make the procedure of PSI more difficult, and the patient is more prone for complications, including death. Number 5, activation of other neurohormonal systems, RAS system, sympathetic nervous system, and other neurohormones. And this neurohormonal have a deleterious effect on cardiovascular system. This is we discussed before, that with progression of renal disease, the mortality and complications increases in patients with acute coronary syndrome. In patients with CKD, we have the classic known risk factor for atherothrombotic disease, smoking, diabetes, dyslipidemia, hypertension. And we have a unique pathogenic mechanisms in uremic syndromes, which includes decreased nitric oxide, increased vascular calcification, hyperhomocystinemia, immune suppression, use of corticosteroids, especially post-transplant, and drugs used for immune suppression. All of these make the atherothrombotic disease or coronary artery disease more common, more severe, and more complication. Patients with CKD, with coronary artery disease, are treated in a classic manner like a patient without coronary artery disease. Let's say, according to clinical presentation, it may be a stable coronary artery disease. The new name for this, it is chronic coronary syndromes. So the recent name of stable coronary artery disease is chronic coronary syndromes. Since 2019, the European Society of Cardiology published chronic coronary syndrome to be used instead of stable coronary artery disease. And the medical emergency, which includes acute coronary syndromes, which include unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. Patient CKD is managed according to the published guidelines of management of chronic coronary syndrome and acute coronary syndromes. We diagnosis by the history, physical examination, non-invasive and invasive test, and each patient is treated. We have optimal medical treatment. We have revascularization, which includes PCI and surgery. Optimal medical treatment is preferred in end-stage renal disease. In milder form of CKD, we can, in selected patient, we can go for percutaneous revascularization or surgery. Unfortunately, the published data about the management of CKD, we have no randomized trials for CKD. All of the available data are available from registries, large registries. This is derived from Swedish registry for treatment of coronary heart disease. We can observe that in grade, this is normal, grade 1, grade 2, grade 3. Invasive strategy is better than optimal medical treatment in patient with extensive coronary heart disease and high syntax score. In patient with end-stage renal disease, unfortunately, invasive strategy is not better than optimal medical treatment. Even optimal medical treatment is better than invasive strategy. So end-stage and dialysis patient, optimal medical treatment gives better result than revascularization, either PCI or surgery. As we have seen together, patients with CKD have more prevalent coronary heart disease. Not only this, a more severe coronary heart disease, which includes 3 vessel disease, means we have a significant narrowing in the major 3 epicardial coronary systems: left anterior descending and diagonal branches, one system; left circumflex and obtuse marginal, one system; and RCA and PDA. This is the 3 systems of the heart. In patient CKD, we have extensive disease affecting the 3 epicardial coronary systems. More serious affection, significant affection of left middle coronary is more common in patient with CKD. More than this, lesion complexity. In last few years, we use syntax trial for lesion complexity. We have more calcified lesion, we have long lesions, and this is calculated by syntax score will result in higher syntax score. I'm sorry. Patient with CKD who underwent PCI have higher in hospital mortality and morbidity. Not only this, 6 months outcome of patient undergoing PCI have a higher cerebrovascular accident. Recurrent ischemia or recurrence of angina is in about 63% of patients. MI in 23, this in 13%. This figures is much more higher if we compare with patient without CKD. And also, restenosis is higher in patient with CKD. I brought for you a case I did for her coronary angiography and intervention. Is a 51 years old male, so young patient, hypertensive, CKD on regular hemodialysis, presented with class 3 angina pectoris despite optimal medical treatment. I did coronary angio for him. We found his right coronary is normal, circumflex total occlusion, the left main LED heavily calcific with a long tight lesion. Heart team and discussion, he was refused by surgeons for CABG. So I did coronary PCI for him at our university hospital on the 2nd of February 2015. I inserted for him 2 drug-eluting stents. I remember him very well. I have heavily calcific left main and left anterior descending. I did standard technique, wiring of the lesion, balloon pre-dilatation, and tried to deploy the coronary stent. I remember well, it didn't pass to the distal lesion and impacted in the left main and proximal LED. So it's risky to throw it. It may prolapse from the balloon. I deployed it in high pressure in the left main and proximal LED. Then I brought a non-compliant balloon for optimization. Then I passed the second stent, the distal one, after the proximal one. This is not usual for us. In patients without CKD or without calcification, we usually start with the distal lesion, then put the proximal lesion. In this particular patient, due to heavy calcification, it was very difficult to go to the distal lesion. I implanted the proximal one first, then the distal one, and optimized the result. The patient, I did for him follow-up coronary angio to the recurrence of symptoms. We can see here, this is the left Schütgen caster, the left main, and here is the stents from there down to there, 2 stents. The stents, after about 5 years, still patent, no significant restenosis, and no stent thrombosis. Again, this is the left anterior descending in a cranial view. This is the left main coronary, and this is the left anterior descending. The circ is totally occluded. Here we have a good flow dystry. This is again left system, right anterior oblique view, and the 2 stents still patent, no significant restenosis or no thrombosis. This is his right coronary artery. I brought this picture. This is the right diagnostic caster, and this is the right coronary artery. You imagine this is heavy calcification of the right coronary artery. Heavy calcification, like metal stent. And fortunately, it is a patent, no significant stenosis. So we have a good flow in the RCA. So we have extensive calcification, but it didn't compromise the lumen. By the way, in the last few years, a significant lesion in coronaries, it is subtotal one, more than 90%. From 40% to 90%, we call it intermediate lesion or borderline lesion. This right coronary have a good lumen and good flow, and it gives collaterals to the left circumflex coronary artery. My colleagues, coronary artery disease is highly prevalent in patients with CKD and carries a very poor prognosis in hospital. 1 month, 6 months, 1 year, it has a higher morbidity and mortality. In patients with CKD, the traditional risk factor, which includes hypertension, diabetes, smoking, dyslipidemia, we have a uremia-specific risk factor play an important role in rapid progression of coronary artery disease among this population. Non-invasive stress testing and coronary angiography are often used to diagnose obstructive coronary artery disease in CKD patients like non-CKD patients. Chronic kidney disease patients with stable or chronic coronary syndromes can be initially managed with optimal medical therapy. And be careful for selection of drugs and doses according to severity of CKD. In selected patients with high syntax score and high extensive coronary artery disease and left pain who are still symptomatic despite optimal medical treatment like our patient, the only solution is revascularization. Revascularization using percutaneous methods, PCI, or coronary artery bypass surgery. The guidelines strongly recommend heart team decision in this type of patient with CKD and high syntax score and extensive disease. We should have non-interventional or cardiologist who doesn't work, did PCR, interventional cardiologist, cardiothoracic surgeons, anesthetist, nephrologist, diabetologist, and we have what we call extended heart team to take the best decision for the patient. The latest guidelines in presence of extensive heart disease, coronary disease, calcification, CKD, diabetics, coronary artery bypass surgery is preferred to PCI, as PCI sometimes may be impossible. The acute complication of coronary artery bypass surgery and mortality is higher than PCI, but the long-term results is better than PCI. By long-term, we mean mortality, revascularization, and hospitalization. PCI is the optimal treatment in patients with extensive disease with low syntax score, absence of calcification, absence of distal left main. The same for PCI. We have higher in hospital complication. We have higher 1 month, 6 months, and 1 year complication compared with patient without CKD. Thank you.
Thank you very much, Professor Gamal, for this very kind and elegant presentation about the coronary intervention in CKD. And I'd like to welcome Professor Nabil Farag, who attended this meeting. Always with full respect to Professor Nabil, because he is a professor who did the BCI for the majority of Mansoura Faculty of Medicine until nowadays we have the Professor Gamal and the cardiology team. So I'd like to hear from Professor Nabil, because one of the most important points that I want to address in this discussion, I prefer not to consider CKD patients as patients for medical therapy alone. And this is your decision, is to stratify the risk and to decide, does this patient need coronary intervention or not? And then we are nephrologists and we are aware by the coronary and by complications, but we advocate intervention nowadays so long as the trusted cardiologist made the risk stratification and decision is to do coronary intervention. And we know well that BCI with drug-eluted stent, so long as the anatomy allows, it's the first step, leaving CABG as the last resort. I'd like to hear from Professor Nabil. The mic is to you.
Thank you very much, Dr. Hussein. I miss you. Thank you very much for your kind invitation, and I enjoyed the presentation of Dr. Gamal. Dr. Gamal is my dear friend a long time ago, since we were young, both. I enjoyed your presentation, Dr. Gamal, and this is a very nice presentation. And as we all know that chronic kidney disease patients were excluded from the major randomized controlled trials. That's why we don't have a clear decision-making as regards the management of such patients. Whether optimal medical therapy is the best or we have to go for intervention. I have some questions to my dear friend, Dr. Gamal, as regards the optimal medical therapy. If we are going to use P2Y12 inhibitors to optimize treatment for a patient with chronic kidney disease, multi-vessel disease, and as you said, the pattern of the disease is usually diffuse in nature. If you want to choose a P2Y12 inhibitors, which one would you prefer? It's the clopidogrel, for example, or ticagrelor or prasugrel. This is number one. It's my number one question. And number two, if we have a patient coming with acute coronary syndrome, unstable angina, non-ST acute coronary syndrome, or ST elevation MI, do you think still optimal medical therapy will be even in patient on dialysis or patient on end-stage renal disease, do you think optimal medical therapy will be sufficient for such patients, or we have to manage such patients as any other patients based on the guidelines?
First, I want to welcome my dear friend, Professor Nabil Farag. By the way, I knew him back 19.
Okay,
The mic,
you should use the mic here. Yes. So the mic. Okay.
So it's great pleasure to be with Professor Nabil. Professor Nabil gave us in Mansoura University hand at our first beginning. So I appreciate his help for us, and he is a good friend for me and for most of Mansoura. Thank you for your two good questions. First, use of antiplatelet patient with CKD and coronary heart disease. I think the patient, the role is to use single antiplatelet, low dose aspirin, so long the patient is stable and controlled and asymptomatic. The chronic coronary syndrome guidelines published 1 year ago, in patients with severe symptoms, we should use dual antiplatelet. For me, I think strong newly introduced antiplatelet, ticagrelor and prasugrel, are more potent and may help in control of symptoms. As I said in the presentation, CKD have a higher thrombotic risk, so we need stronger. At the same time, he has a higher bleeding risk due to platelet dysfunction. So every patient should be tailored. If the patient haven't higher bleeding risk, I prefer, and highly symptomatic, strong antiplatelet ticagrelor and prasugrel is preferred to clopidogrel. And I think there is published data. Ticagrelor provided a mortality benefit in patients with chronic coronary syndromes and CKD. The second question is very important and touch a very important common, or maybe the commonest medical emergency with acute coronary syndromes, unstable angina, non-STEMI, and STEMI. A patient with this serious presentation should be managed like other patient without CKD. Let's say will apply guideline evidence, do risk stratification in patient with high risk and non-STEMI with sizable infarctions or unstable angina. Coronary angiography, according to guidelines, may be immediate within 2 hours or early in this strategy is preferred. Optimal medical treatment in this situation will not add nothing. And the mortality is higher in patient managed medically with presented with acute coronary syndrome. So patient with CKD and acute coronary syndrome, including unstable angina, non-STEMI, and STEMI, should be managed like any other patient without CKD, as early angio and revascularization produces a mortality benefit in this sector of patient.
If you allow me, Professor Nabil, I like your questions very much. And I'd like to add a comment about the issue of antiplatelet in CKD and dialysis. In the past, we are afraid of bleeding with antiplatelets, but we learned it a lot that with the lower the GFR and with the development of CKD, the higher the stage of CKD, the lower the response to antiplatelets. So CKD is considered as clopidogrel resistant states. There are some patients, and fortunately they are a minority, who may have bleeding. So currently, thrombotic events is the most common. This is why we shouldn't be reluctant in giving antiplatelet for our patients. Even dual antiplatelets, okay, because CKD is a state of antiplatelet resistance. But if the patient has vivid, clear bleeding, I can manipulate this patient because I'll be afraid. There are many interactions with the drugs that we give to the patients interact with clopidogrel, reducing absorption, reducing metabolism, because it is a drug, pro-drug, and to be effective should be metabolized. This is why this can explain partially the state of resistance. I'd like the second question, because this is our goal from this meeting. This is the call for cardiologists. Please don't deprive CKD or dialysis patients from coronary intervention so long as you find it is indicated. Yes, mortality is high with our patients, but mortality will be even more if coronary intervention is needed and delayed. Dr. Nabil.
Thank you, Hussein. I'm very happy with your answer, because myself, it's a chronic kidney disease patients we deal with this type of patient exactly as diabetic patients, because the pattern of atherosclerotic coronary artery disease in diabetic patients is similar to those with chronic kidney disease. And if we go to the dyslipidemia guidelines, if as regard the risk category of patients, they put patients with chronic kidney disease who have a GFR of less than 30 as a very high risk patients. Very high risk patients should be exactly like patients with established atherosclerotic cardiovascular disease. So a chronic kidney disease, a severe form with an end-stage renal disease, even without evidence of coronary artery disease, should be treated exactly like those who have established atherosclerotic coronary artery disease, and this is based on the European Society of Cardiology guidelines in 2019, the recent dyslipidemia guidelines. So it's a very important part of our daily practice, and again, because we don't have a clear evidence of how can we treat such patients. We don't have an algorithm, a clear algorithm based on major clinical trials for how to treat. So we have to treat this patient aggressively as regard optimal medical therapy. And as Dr. Hussein and Dr. Gamal said, I think dual antiplatelet therapy will be suitable for patients with established atherosclerotic cardiovascular disease, even if they are stable, because the pattern is diffuse and multi-vessel, and they have a high risk of developing acute coronary syndrome and mortality. And the P2Y12 inhibitors, again, we choose a potent one, as Dr. Hussein said, even if the bleeding risk is, we know that the bleeding risk might be high in such patients, but the thrombotic risk is higher, and we balance between both. So the choice of a potent P2Y12 inhibitors like ticagrelor or prasugrel is important. And coronary intervention is important in a patient with acute coronary syndrome based on risk stratification, as Dr. Gamal said, and patient with STEMI patient should be treated like any STEMI patient with a primary PCI, whatever the level of the creatinine is, because it's a life-saving procedure. We save the life of our patients. And I think there is an important question here in chat, not in the patient asking about which is better for a patient with chronic kidney disease in assessment of cardiac status, which is CT, coronary angiography, or cardiac angiography. Dr. Gamal, if you want to answer this, and if you want me to answer, it's...
Please go ahead, Dr. Nabil.
For cardiac assessment, we don't run directly to either CT angiography or coronary angiography in such patients. We assess with non-invasive tests like radioisotope study, like the vitamin echo. We are trying to avoid the use of contrast media as much as we can in such patients. But if the patient is in need to assess the coronary anatomy with either CT coronary angiography or a coronary or a diagnostic cardiac case, myself, I prefer to go to the cardiac case, because the amount of dye we use in cardiac case is much less than those used in the CT coronary angiography. The amount of dye used in CT coronary angiography is between 80 to 100 milli, and we can do the diagnostic coronary angiography with only 30 or 40 milli contrast. So this difference in amount of dye will help to prevent development of renal failure and to enter into dialysis in such a patient. But this is the last step based on non-invasive evaluation first for the cardiac assessment. And if and this is as answer to your questions. And I think there is another question by the end of the day, cabbage is superior to PCI. If Dr. Hussein, if you want to add something,
yes,
Dr. Gamal.
Yes, please. Do you trust CT? I don't trust CT in the presence of chronic kidney disease and dialysis. I would like to hear from you and Professor Gamal. Do you trust CT for evaluation of coronary calcification?
Yeah,
because
this is
the environment of CKD is calcification and maybe medial calcification, as the case presented elegantly by Professor Gamal. Do you trust the CT or not?
Yes. This is very important, Dr. Hussein. For actually, patient with chronic kidney disease, the pattern of atherosclerosis is calcified lesions. They have some form of calcification, and this makes CT coronary angiography assessment will be inaccurate due to the presence of calcification, which is common in patients with chronic kidney disease. So, as you said, the diagnostic efficacy and sensitivity of CT coronary angiography in a patient with chronic kidney disease will be not good as definitely the gold standard coronary angiography. This is mainly because of the presence of calcification in such patients.
I do agree 100% with my friend and colleague, Professor Nabil Farag. CT coronary angiography, it has a role in a low-risk patient, even without patient without CKD. In presence of high-risk criteria, no role for CT coronary. As Professor Nabil said, the gold in nowadays, and maybe for the first few years, the gold standard for diagnosis and risk stratification of coronary artery disease is invasive and conventional coronary angiography with precautions for the type of contrast and amount and good hydration and so on. In presence of calcium, no role for CT coronary. In presence of high-risk criteria, no role for CT coronary, even in absence of CKD. So CT coronary, it has a role in low-risk patients only, but intermediate and high-risk conventional and invasive coronary angiography is the gold standard for diagnosis.
To add a point to Professor Nabil, regarding why there is no evidence-based recommendation for CKD dialysis patients regarding coronary intervention. This is because in the majority of clinical trials, the patients with advanced CKD and dialysis are excluded from the trial. This is why in the short term will not find any evidence base. But I'm believer in the coronary perfusion, and every minute carries a worse prognosis. That's why this is a call for all cardiologists. Please don't deprive the patients from this help of revascularization, even if the outcome is less than regular patients. This is one of our points. I have a question to both of you, Professor Nabil and Professor Gamal, regarding because this is one of the questions before arrival of Professor Gamal. If we have a patient in the stage kidney disease and prepared for transplantation, how to prepare him from the cardiology? If the patient has evidence of ECG or a history or symptoms, whatever, what would be your advice? How to give this patient clearance to go ahead for transplantation, or first to do coronary intervention, then to go from transplantation? I'd like to hear from you, Professor Nabil, and from Professor Gamal, what is the best to be followed?
This is a very important question because we face such patients and frequently. Patients who are prepared for transplantation and want to assess their cardiac condition before this major operation. Usually, I'm doing the list or the simple test before. We ask the patient as regards symptoms. If he has no symptoms at all, he walks normally, climbs stairs, and do his daily activities normally. And if his ECG is normal, in such patients, I don't go for a coronary angiography, but I ask for some sort of non-invasive evaluation, and I prefer the dobutamine stress echo or radioisotopic study. And if this test is negative, I can send this patient to a transplantation safely. But if the patient has symptoms, classic symptoms of angina, and has an ECG changes of ischemic heart disease, in such patients, I prefer to go to a coronary angiography to assess the severity of the coronary artery disease and to know the coronary anatomy, and to go to intervention. And now we can do intervention with the drug-eluting stents that can stop the dual antiplatelet therapy as early as 1 month after intervention if the patient is in urgent need for transplantation. Or we can extend it to 3 or 6 months if the patient can wait for this. So based on the clinical status of the patient, based on the bedside assessment of the patient, I will ask either non-invasive test or coronary angiography. And if the patient in need for intervention, I will do this with new generation drug-eluting stents to be ready to stop the dual antiplatelet therapy as early as 1 month, then to go to the transplantation.
But routine coronary intervention is not mandatory for all.
Yes,
So
yes. No routine coronary angiography. Yes, yes.
Okay. Dr. Gamal?
Exactly, Prof. Nabil. And I have the privilege that we have urology and nephrology center at Mansoura, one of the best in the Robert World. And I have seen many cases before transplantation. If the patient is asymptomatic, no multiple risk factors, non-invasive tests, very good resting ECG, echo, and so on, and young age, I give him priority to go for transplantation.
Yes.
If I have a symptomatic patient, multiple risk factors, ECG changes, wall motion changes, I proceed for invasive conventional coronary angiography and revascularization. Then I refer him for renal transplantation. As Prof. Nabil said, we are fortunate that the new generation of drug-eluting stent we can stop dual antiplatelet after 1 month or 3 months. So coronary angiography only in high-risk patient, symptomatic with evidence of ischemia, non-invasive test. I do agree 100%.
Dr. Yasser Al-Mulla, do you have, please, I'd like to hear from you, your question.
Many thanks, great talk. So can I just say about screening for prior to the transplant for asymptomatic patient? There is no doubt about what you said about symptomatic patient, but for asymptomatic patient, the minimum you do is ECG, echo, and possibly dobutamine stress echo or a myocardial perfusion scan. Am I right in saying this? That's the minimum.
Yes.
You would do an echo and stress echo. Perfect, excellent. Because like that's what we used to do as well, with the exception of diabetic patient, that we used to send them for a formal angio regardless, even if they are completely asymptomatic, but they're diabetic and they're on insulin with even a normal ECG, normal exercise tolerance. Here, we used to send them for a formal coronary angiogram prior to the transplant. But now, because of the CKD ischemia trial, like there is a lot of debate, and some of the centers, they stopped even doing echo and they stopped doing the stress echo for asymptomatic patient, and they're saying ECG is enough. But I liked your answer. And one more question about the pre-transplant assessment. What's the cutoff ejection fraction that you will give a clearance for the patient to proceed with a transplant? Is there a cutoff ejection fraction that you will give a clearance? Because here in the UK now, some of them are saying 45%, some of them are saying 40%, some of them are saying 50%, provided that they are euvolemic, there is no concern about fluid overload, and there is no concern about ischemia on a cardiac workup. Thank you.
Thank you very much, Dr. Yasser, Dr. Nabil, and Dr. Gamal. Professor Nabil?
Thank you very much, Dr. Yasser.
Yes. The cutoff point of the ejection fraction, you can get clearance to proceed for transplantation. Because
yeah, you know, based on Based on the European Society of Cardiology guidelines, they classify patients with heart failure into those with preserved function and those with reduced function. Reduced function means less than 40. And this was a mid-range ejection fraction between 40 and 50. And I think 40 is a cutoff point below which it would be high risk to go for transplantation unless the patient is treated well. And we have now the medications that can improve the ejection fraction and to go above 40. And this is evident in the American College of Cardiology. They call this type of patient heart failure like mid-range but improved with medical treatment. They were reduced ejection fraction, but they are improved with medical treatment. So my answer is the cutoff point based on all of these data is 40. Above 40 is allowed to go for transplantation, provided that the echo is done properly and the assessment is good. And below 40, I think we can go for optimal medical therapy for heart failure, and this will help to improve the ejection fraction to go above 40 and to make the patient ready for the operation. Yasser, you mentioned a very important point as regard patients who are asymptomatic, stable patients, and even they don't ask for echo or stress dopamine echo. Yes, it's a good point because you know it's based on the new guidelines, European Society of Cardiology guidelines, as regard chronic coronary syndromes. We can put a specific probability. We have low probability, intermediate, and high probability. And if the patient is in low probability, we don't need to ask for further investigations. But if the patient is intermediate or high probability, we can ask for further tests. And this probability is based on many factors like age, sex, and other risk factors, as mentioned in these new guidelines. So based on the probability of the presence or absence of ischemic heart disease, I will go for further tests. If probability is low, I will stop with simple tests like ECG. If the probability is intermediate or high, I will go for further tests like the vitamin echo, or even if it's very high, I can go for a coronary angiography.
Yes, I do agree with Professor Nabil, and I have in urology nephrology center in Mansoura, I have seen many patients, young age, with impaired cardiac function, low ejection fraction, maybe 30 or lower. I give them, as Prof. Nabil said, optimal medical treatment, which includes neurohormonal blockers and beta blockers, and follow up of them, many of them at young age, the heart failure manifestation controlled, dyspnea and short breath with improvement in effort tolerance, follow up of ejection fraction improves, and the same 40 is the cut-off point. More than 40 with clinical control of heart failure and hypervolemia. I have many patients at this center, young age, heart failure symptoms, impaired systolic function. By optimal medical treatment, they improve. But we should give adequate time, 3 months, 6 months, as this takes time. And I have many, I'm fortunate, they underwent transplantation surgery and improved. We have many. So control of heart failure manifestation, volume status, optimal medical treatment, improvement of hemoglobin concentration, and treatment of anemia. Beside neurohormonal blockers for heart failure, many patients improve, but should allow adequate time. The patient will not improve in 2 weeks or 3 weeks or 1 month or so. So it takes time, 3 to 6 months, and many improve.
you allow me, Professor Nabil and Professor Gamal, I have just a point. The uremic cardiomyopathy, which is the patient on dialysis with low ejection fraction, these patients, yes, we should maximize medical treatment, maximize dialysis, because the uremic cardiomyopathy is partially reversible by adequate dialysis, and we evaluate the patient by physical tolerance, and put in mind that after kidney transplantation and clearance of uremia, heart will improve. And we have here a study that confirmed improvement of the cardiac function after kidney transplantation. This is why the cutoff point 40, for us, we can agree about 30 even, so long as the patient is fit, moving, we should optimize dialysis and go ahead for transplantation. And by transplantation, the heart will improve, and the anesthetist is clever enough to assist the patient, so long as the anesthetist agreed to go ahead for transplantation, we'll go ahead. So it is multidisciplinary, yes, multidisciplinary approach. The cutoff point is debatable, and it depends upon the state of the patient overall, and the agreement of anesthetist. Cardiologist, by the way, is the most important, because he is the cardiologist to give us the clearance to receive, even from medical legal point of view. Dr. Nabil, what's your comment about this point? We still have a comment from Professor Hussein Sheashaa, and we will stop at this moment. Dr. Nabil. Dr. Nabil, yes.
Sorry, Hussein, I couldn't.
The cutoff point of ejection fraction, we don't fully agree.
I prefer to be 40. You know, 40 is good for.
Let us to say above 40 is okay. Less than 40, we individualize. We assess the patients on individual base. Okay. Do you agree about
Yes,
this?
less than 40, I will optimize medical therapy to raise it to above 40.
Okay, Dr. Faisal. Dr. Faisal, then Dr. Sahil. Dr. Faisal.
Okay, thank you very much. Thank you, Hussein. I'm sorry I'm on duty, so that's why I'm in the hospital now. Actually, I enjoyed so much what the lecture from Gamal and the comment from Dr. Nabil, Prof. Nabil. Both are excellent, and I like the conclusion about pre-transplant workup from the cardiology, especially the point which mentioned by our colleague Yasser about the patient who is diabetic. And usually our protocol is anyone who is over 45 and diabetic, he should go for CT angio to exclude anything. But it was very informative talk, and I think we are with the cardiologist in the same boat, going together to help the patient. Thank you very much.
Thank you very much. Dr. Sahir Khashab.
Thank you, Dr. Nabil. So, thank you, Dr. Gamal, for the nice talk. I would like just to ask about your experience in carbon dioxide coronary angio, because as you know, most of our patients who have a creatinine of 4 or 5 or 6 and are ischemic, we are always afraid of doing them a coronary angio because of the dye. And recently, the vascular surgeons, they don't use anymore the dye, and they use the carbon dioxide. So what's the role of the carbon dioxide coronary angio from your experience?
Dr. Nabil?
Yes, this is very important questions, and myself, I don't have any experience with carbon dioxide, and we hear about this a long time ago, actually. But what we do now, just we have to prepare our patients very good before going to a coronary angiography. Patients with a chronic kidney disease should be admitted at least 1 day before the coronary angiography, and hydration is the cornerstone in the prevention of contrast-induced nephropathy in such patients. So hydration, sometimes we can use things like acetylcysteine, but hydration is the most important part in the prevention of contrast-induced nephropathy. We have either patient with normal ejection fraction, and this we can give a dose, the normal dose of saline. We use saline, which is 1 milli per kg per hour over at least 18 hours, up to 24 hours before the procedure. And if the patient is having some sort of heart failure and elevated function, we can give half dose of this saline over 18 to 24 hours. Second, we have to use non-ionic dye, and we have to use the minimal amount of dye. As I said before, we can control the amount of dye during the coronary angiography. We can do it with a very small amount, up to 30 milli contrast. With all of these precautions, usually we can prevent the development of renal failure, or to have, or to need sessions or more dialysis. So this is what we do in our chronic kidney disease patients. Myself, I don't have any experience with carbon dioxide, and even when I attend or I share in international conference in Europe or in USA, they present patients with chronic kidney disease, and they use the non-ionic dye with these precautions I said, and I didn't see any patients who did coronary angiography with the carbon dioxide. So I don't have any experience, and what we do, as I said before, is a proper preparation and the use of non-ionic dye, a very small amount for the coronary angiography.
I think this is an interesting point. I had one of the presentations on the YouTube since 2012 about contrast associated with contrast induced acute injury, and I reported the issue of carbon, but as Professor Nabil mentioned, it seems that it's not practical up to this moment. And the best way is to use the minimum amount of contrast, and I like the minimum 30. It's okay, 30 milliliter is very nice, fantastic. So the professional cardiologist can make a great difference. So avoiding dehydration and using the minimum amount of non-ionic contrast, either low or isoosmolar, I think this is the best way, because this is, and I also remember some sophisticated catheters that allow injection of the contrast and withdrawal of the contrast after injection. I think it's still not practical, and it is very, very expensive. This is why meticulous, thorough, to be sincere and avoiding excess contrast, it is the best way. I remember one of my presentation in Nigeria, when I was asked from the professor of radiology, what you mentioned, non-ionic, low osmolar, we don't have non-ionic. All we have high osmolar contrast, the oldest one. I said to him, dear sir, still you have something to do. Please use little amount of contrast that allow you to interpret the films. You don't satisfy the surgeon, because surgeons would like to find the vessel is clear, crystal clear. This means a lot of comorbidity. Dr. Gamal.
Yes. I have no experience like Professor Nabil in carbon dioxide angiography, but I have did conventional angiography for many patients with different grades of CKD. And I have the honor to present the presentation about contrast-induced acute kidney injury in your society. The conclusion that use the least amount of contrast, the most important thing, which make a difference in acute kidney injury, is good hydration. Pre-procedure, minimum 6 hours. During the procedure and after the procedure. A normal saline is the best. I have 2 months ago a patient with diabetic, heavily calcific left anterior descending. It was technically very difficult. I used the many stents and pin wires. It was prolonged procedure, but I gave him good hydration before the procedure, during the procedure, and after the procedure. The availability of isoosmolar, idoxinol or Visipac, it is preferred in patients with advanced kidney disease. In patient with mild degree of CKD, who can use low osmolar contrast agent, the same smallest amount, to get what you need only from coronary anatomy. Just you have a clear idea. You image the major the coronaries in minimum number of views. You can take the decision. This is sufficient. But as Prof. Nabil said and Prof. said, hydration, hydration, hydration. It will make a difference. And contrast, acute kidney injury contrast course, we know it very well. And stoppage of nephrotoxic drugs, very important. And we ask for serum create after 72 hours, after 7 days, and after 10 days. Most of the patients may develop a mild degree of acute kidney injury. And most of the patients with good preparation will recover in 10 days. In 10 days, we can sometimes, after revascularization, the kidney function improves due to improvement in renal perfusion. And I have many patients, this happened with them.
Thank you very much, Professor Gamal, for these points. Dr. Sahir, do you have any points you like to?
Yes, thank you for your answer, Dr. Nabil and Dr. Gamal. And actually, I want to emphasize that I actually asked every cardiologist I know, also in Asr Al Aini in Cairo University. I had the same answer, that they don't have an experience in carbon dioxide angio. And apparently, there is some concern about trying that in patients. However, it would solve lots of our problems, us nephrologists. The second point I want to comment on, because I know some young nephrologists are attending this meeting, is that I hope you agree with me, Dr. Hussein, that there is no role of preventive hemodialysis in contrast-induced nephropathy. So you don't.
Dr. Sahir, we had 1 hour before arrival of Professor Gamal, and we discussed the issue of contrast thoroughly
Yes.
with the audience, and nothing is well known as prophylactic dialysis. We do dialysis if dialysis is indicated based on the clinical indications that all of us know. But to inject contrast and to do dialysis to remove the contrast, it is not for preventive or contrast associated kidney. Okay.
Thank you very much.
Thank you very much, Professor Sahir. Because of your time, and I think we are very late, I would like to thank and appreciate the presence of Professor Gamal. This is a really wonderful presentation, and always we work in collaboration. And one of the most important statements you mentioned, Professor Gamal, is we are working in a team. So this is a team-based discussion, and with the team-based discussion, the patient will be very satisfied. This night we have one of the eminent and the stars of cardiology in Arab world, Professor Nabil Farag. All of us are appreciating your presence with us, and I'm personally appreciating your efforts with me. And I presented some of your research in the introduction, but I'd like to conclude this session by a symbol of appreciation to Professor Gamal from the Egyptian Society of Nephrology and Transplantation, Continuous Medicine chapter, for this very interesting talk about coronary intervention in CKD and renal transplantation. Also, it is a symbol of appreciation and respect to dear great Professor Nabil Farag for his time and for his valuable comments. Thank you very much, appreciating. And I'd like to stop to leave Professor Nabil to close the session. Dr. Nabil.
Thank you very much, Dr. Hussein. I enjoyed this discussion and this session very, very much. And as Dr. Faisal said, we are in the same boat. We work together. We are a team, actually. And we are trying to help each other. For our work, we need you very much. We need the nephrologist very much to have your consultations and even to assess in patients who might need dialysis, and who ask for your advice as regards these patients. And I think it's a very good team to work together. And this should be the spirit in all the hospitals, that doctors should work together for the sake of the patient and for the benefit of the patient, because a teamwork will be reflected on the best outcome of our patients. I would like to thank you all. I would like to thank you, Dr. Hussein. I would like to thank you, Dr. Gamal. I would like to thank Dr. Faisal, Dr. Yasser, Dr. Amanel, Dr. Sahir. And I'd like to thank you all for your kind listening and discussing this important topic. Thank you, and I hope to meet again and to meet face to face next time, not virtual.
Thank you very much. Thank you, Professor Nabil. Thank you, and thank you all for attending. And tomorrow I'm going to upload the presentation to this. Thank you and goodbye.